All right, so this is going to be a video for Christina Howard's Biology 242 class at Clark College. I'm recording this video for the summer 2022 portion, but it's going to just go ahead and stay up. So if you are a student from the future, hello from the past. All right, so this glossy alien-looking thing we have before us is the female reproductive system. And when I say female here, I just want everybody to be aware that I'm using that term in the genetic and anatomical sense of biologically female, because, sorry, I'm just trying to figure out how best to move this thing around since it feels like there's a little bit of a lag. Because, of course, I want to make it clear that I'm not gendering this anatomy. I am talking about strictly the biological sex based on this person's presumed chromosomal organization and the hormones and therefore the development that most often result from that. Okay, so I was trying to zoom out because I wanted to give you an overview, and I think I'm going to hide annotations if I can. Maybe. There we go. Hide annotations. Okay. Sorry, this is a little bit irritating. This is being very slow today, but that's probably because it's quite a complex 3D model, for which I am very grateful. Okay, so first what I'm going to do is spin this around from the side. Perfect. And what we're going to do is establish some direction, and then I'll point out organs, and then we'll kind of zoom in and look at various aspects of those. The reason being is that when you're confronted with something that looks like this, and you're just learning, and you're like, oh my god, what is that? Is it an alien? The first step to orienting yourself is, of course, to figure out, which way is up, essentially, and which way is down, left, right, etc. So, this is the anterior aspect, and this is posterior, and this is inferior, and this is superior. Hold on, I'm so sorry. I'm going to pause because my husky is in his kennel making a bunch of noise, and I need for him to not do that as much, so I'm going to go give him something to do. Okay, I'm back. So sorry about that. Having a 7-month-old Siberian Husky is a lot of work. Okay, so now that we've established some direction, I'm going to use a different color, and I'm just going to point out some of the organs. We're not going to do an in-depth dive yet. Because we have the directions in front of us, it's nice to be able to add the organs in so that you kind of have a good working knowledge of where stuff is relative to other stuff, if that makes sense. So let's try this. So this is the bladder, and this is the uterus, and that is an ovary. These tubes, there's one per side, are the ureters, which is the tube that brings urine to the bladder from the kidneys. And then down here, we have the labia, and we also have various clitoral structures. And if you're thinking to yourself, I thought the clitoris was just at the front. Nope, it's larger than that, and we'll look at that too. But that's just kind of a working, let's add in the, of course, fallopian tube right there. Okay, so that's a basic overview of what is what in this really, really nice detailed 3D model. Oh, and then here we have the vagina. Okay, so let's go piece by piece and look at each part of this, and that will help us better understand the physiology of the urinary and reproductive system in the pelvis, as well as the anatomy. So, as always, we learn anatomy and physiology. That's why it's called A&P, because the form something takes, the structure, is directly related to and determines that thing's function. Okay, so let's look at what the view would be if we were looking from the anterior aspect. So I'm going to go ahead and just turn this. There we go. So if you're wondering, like, what is this weird thing right in the middle? That is the umbilical ligament. And that actually attaches to your belly button, believe it or not. So part of the urogenital development, which is the development during embryonic and fetal life of the urinary system and the reproductive system, is that part of that stuff had a direct connection to the umbilical cord and therefore to the placenta. And if you think about what the purpose of the urinary bladder is, which is to store urine, which is a waste, then it makes sense that your former waste removal system, which is the umbilical cord, would be involved as well. So this is just a leftover of that. So we can see, I'm going to spin this a little bit. This lag is really annoying me. There we go. I have to do it with my finger, not with my stylus. Okay. So this is looking from the front, and what you can see is the uterus, which I will label again, is sitting on top of the bladder. And then we have one fallopian tube per side. And then here's the fallopian tube on the other side. And above and posterior to the uterus are the two ovaries, which the fallopian tube is ending near. And so if this was in situ, meaning in an actual pelvis, and that pelvis was visible, what you would see would be that the ovaries are kind of close to the pelvic wall, and that all of this would be enclosed in a sheath of connective tissue, which is called the broad ligament, but it's been subtracted here so that we can see the other structures. And then we can see that down here, this area represents the floor of the pelvis, and that's where you find the vaginal and urethral orifices, as well as the labia and some of the erectile tissues of the clitoris. So what I'm going to do now is rotate this model so that it would be the view that a gynecologist would have if they were doing a pelvic exam on somebody with this anatomy. Rotating, there we go. Okay, so now we're having basically the view that a gynecologist would get. So looking at the vulva, and I want to be clear about what I mean when I say vulva, because some people mistakenly use the term vulva and vagina interchangeably, and that is just not true, not based in fact. So the vulva is the collection of tissues which make up the external genitalia. So in this case, we've got, and I'm just going to write vulva over here. I know my V's and my U's look the same here. Let's fix that. Vulva. And we're going to make subheadings under that because the following structures are what is making up the group structure called the vulva. So the vulva consists of 2 labia majora, 2 labia minora, And those are the lips of skin and fleshy tissue that surround this area that's in the center here, called the vestibule. And then the vestibule contains two orifices, which I'll use a different color for. So this little hole right here is the external urethral orifice. And then this down here is the vaginal orifice, or vaginal opening. So two things to note. The urethral orifice and the vaginal orifice are separate openings. I want to be very explicit about that because due to the fact that sex education in the United States is not always that great, and in some other countries too, there are some cultural aspects of that, I'm not going to weigh in on or pass judgment on. I'm just saying sometimes people don't get educated about their parts or other people's parts, and that creates misunderstandings. So in an effort to dispel those misunderstandings and get everybody who comes to watch this video on the same page, the urethra, urine passes through that out from the bladder. That's the only function of the urethra here. The vaginal orifice, which I'm not using interchangeably with the word vagina on purpose because the vagina is a muscular tube. The vaginal orifice is the opening between that tube and the outside world. So it's an opening. The vagina itself is the tube. So if you are looking at the gynecological view, where this is the ventral surface, meaning that that's the belly side of a human, or the front, the urethra and its opening are above the vagina and its opening. Two holes, one above, one below. So, other aspects of the vulva we can continue to label. You'll notice that there is a little nub of flesh right there. That is the glans clitoris. Which is analogous and indeed homologous to the glans penis. Developmentally, both of those structures that I just named used to be the same thing. But depending on which hormones are present during development, they differentiate during development and end up being different but very similar structures. So the glans clitoris is the quote-unquote head of the clitoris. And just like in the male repro side, the glans is covered over by a prepuce or a foreskin, which is sometimes also called the clitoral hood in this case, because it looks like if the glans clitoris was a person's face, then they'd be wearing a hood, and that's what the prepuce is. So the prepuce is that hood over the glans clitoris. Now, there's a reason I'm not just saying clitoris only, and that is because the clitoris has a glans, which is the external protruding part, but it also has other structures which are underneath the labia minora and majora and buried in the tissue, and these are not often discussed. But the clitoris is actually a lot larger than most people believe that it is. All right, so that's the vulva, and that's what we see here. So now I'm going to sort of rotate this to the side, and we're going to look at some other aspects of what's going on in that pelvic floor area, and then we're going to go up from there and look at the vagina, the uterus, and the other structures. Okay, so I had to pause and switch views. There's some lag happening, but we're back now, and we're in business. So this is a closer view, and we're going to discuss the internal structures of the clitoris that are not visible from the outside, and then we'll have a look at some of the glands, and then we'll look at the vagina and sort of move up from there. So we've already established that there is a glans or head and a prepuce to the clitoris. So here we have our glans. This hood is the prepuce, which is a fleshy covering. And for both the penis and the clitoris, the prepuce is there because the glans is very heavily innervated and it's incredibly sensitive. And for that reason, it's uncomfortable if it's like bumping up against things all day. So part of the function of the prepuce is just to protect it from overstimulation. Now, we also have these structures here. And these would be underneath the labia majora. So not visible from the outside. And they are the crus of the clitoris. And so these are analogous to the other erectile tissues of the penis, the corpora cavernosa, which are not the glans part. So still erectile tissues, meaning still tissues that fill with blood and become engorged and turgid. Turgid meaning stiff due to hydrostatic pressure inside. So they become engorged and turgid during the arousal phase of the human sexual response, just like a penis does. It's just a slightly different shape and smaller version. And then also underneath the labia majora, we have the vestibular bulb. One per side. And those are also considered to be a structure of the clitoris. So all of these things that I've just labeled are going to be stuff that's not visible from the outside, but which is involved in the human sexual response, specifically the initial arousal phase, and is related to the pleasurable aspect of sexual intercourse, including, but not limited to, moving towards and arriving at climax. And if you're like, how are you so comfortable talking about all this stuff without giggling? The answer is, well, it's biology, A, and B. Many people throughout history have had sex, believe it or not. That's how we make more humans. And it's just important to be able to talk about this stuff with a straight face and have frank discussions about it, because treating it as something that we don't talk about or something which is silly and giggly, again, is how misunderstandings are created about human sexual biology, and I want to avoid those. So, I've also had a lot of practice. Obviously, I'm an A&P professor, so I can say penis and vagina all day without ever cracking a smile. Okay, so that is clitoral anatomy that you need to know, and it is a need to know. It's very important that everybody understands everybody else's sex parts. All right, so now let's move a little bit downward. There's the vestibular bulb, and vestibular refers to, of course, the vestibule, which is this guy, that little pelvic floor area. But we've also got the vestibular glands, which there's one per side. So they're not the same thing as the bulb. My pen is not behaving itself. There we go. And these are also called Bartholin's glands. So if you see that terminology, just know that those two terms are interchangeable. They're both correct. It's just two different names for the same thing. So the vestibular glands, or Bartholin's glands, they actually, and it's not really shown very well in this model, unfortunately, but they have, you can see a little tube. I'll show it from the side as well. And this tube or duct opens up right about here. So on either side of the vaginal orifice, you've got these two openings that open onto the duct that carries the secretions of the Bartholin's gland away from the gland and out into the vestibule. So the purpose of this secretion, again, during the arousal phase of the human sexual response, is to lubricate the vestibule, which eases the process of intromission. So let me write that word real quick. There we go. So intromission. Intromission is the anatomical and biological term, and it's not limited to humans. This means insertion of one sex organ into another, and that is to achieve internal fertilization. So there's plenty of creatures on the earth that do external fertilization. Fish are a great example. If I'm a female fish, I'm going to dump a bunch of eggs into a nest or maybe just into the water. And then those eggs are fertilized by a male fish coming along and dumping a bunch of semen on top of those eggs, but it's all happening out in the open. So that's external fertilization. Internal fertilization has lots of advantages, and one of them is that it doesn't put the resulting embryos at such risk of being destroyed. But if you're going to do fertilization internally, it has to be internal, so you have to have one thing going into another thing. And so for mammals and for us, that means an erect penis entering a vaginal canal. So that's what I mean when I say intromission. I mean insertion, in this case, of the penis into the vagina. So because all of this anatomy is very specialized, but also, kind of up in a crevice and a little bit hard to access, there's a bunch of criteria that have to be met in order for intromission to be successful. One of them is having the penis be turgid enough to actually make it through the elastic opening of the vaginal orifice, but the other one is lubrication. So the vestibular glands, during the arousal phase, they will make this sort of clear, mucousy, but also very slippery secretion that just helps to lubricate the passage of the penis through the vaginal orifice and help intromission actually be achievable. So that's what they're there for. Clinical note for my future doctors and nurses, most of you are probably that, is there's a gynecological condition called a Bartholin's gland cyst. And this typically happens when the duct to one of the Bartholin's glands gets blocked for some reason, and or bacteria make their way up into the Bartholin's gland through the opening to its duct, and it becomes inflamed and very pressurized because it's surrounded by connective tissue, and they're very, very painful for the people that suffer from them. So that's, if you're going to end up working in the emergency room, for example, that might be one of your emergency room visits, because usually when somebody has a Bartholin's gland cyst, the average Joe doesn't know what a Bartholin's gland is. All they know is that the lower part of their vulva feels very pressury and tender and like it's on fire, and they tend to just go to the emergency room for that reason. So now you know that they're not dying. It's a Bartholin's gland cyst, and it's a manageable, treatable situation. Okay, so let's look at some more stuff. There's a lot going on here, as you can see. So I'm going to rotate this way. Whoa, that's a little bit too much. I guess I just need to go slow because this is a very jumpy model. Okay, gently, gently. Perfect. Okay, so now you can see this is the urethra, which carries urine from the bladder and out. And then we've got the vagina here. The vagina is an elastic muscular tube lined with non-keratinized stratified squamous epithelium. And the purpose of the vagina is to do a bunch of things. One is permit intromission for internal fertilization during sexual intercourse. The other is allow fetus or menstrual tissue to exit. So, interesting vagina facts. The vagina on average is only about 4 to 5 centimeters deep. So it's much shorter than many people believe, but it is extremely stretchy and elastic. So it is able to expand and shift around to accommodate various things, including but not limited to the entire head of a fetus, which, as you might imagine, is quite a bit larger than a vagina, and also a human penis. Okay, so let's zoom in and look at some vagina features, because it's just, in spite of it being something that about 50% of humans on Earth have, it's just not a very well understood organ. So on the inside, it is ridged, and that's partially a result of it being stretchy. So kind of like a scrunchie, like where if you have, if the scrunchie is relaxed, the fabric is ruffled up and frilly, and if the scrunchie is stretched, then it's not. Same deal with the vagina. So these are just kind of the ridges that are a result of the relaxed state of it, permitting it to stretch back out. So it's primarily made of, as I said, squamous epithelium, but also elastic connective tissue, fibrous connective tissue, and smooth muscle. And then the vagina, as you can see up here, it doesn't plug into or narrow to the opening of the cervix. Instead, the cervix, which is the neck part of the uterus, so right there, it sits down in the vagina, kind of like I'm trying to think of a good analogy for this. Like if you had like a spherical object or model and you rested it in something for its display holder, and it was like you put the sphere in like a little circle-shaped stand, so it sits down in there, and that's what stabilizes it. Same idea here. So because of that, the vagina is expanded at this end, so it's wider towards the uterus than it is at the entrance. And it's also got this little pocket of space around the cervix, which is called... Oh, am I not allowed to draw anymore? All right. Well, that's great. I think my Epic pen has frozen. Hopefully this record... Oh, no, there it goes. Okay. So I guess I just need to be very careful. Or maybe my pen's running out of batteries. That's another possibility. So this, yes, it appears to be my pen, is called the salpinx, which is the little pocket of space around the cervix. And so the reason I am emphasizing the salpinx here is because, as you can see from this anatomy, the vagina is a blind-ended pouch. There is no opening of it into the pelvic cavity. You can't lose anything in there. However, people sometimes come to the emergency department concerned that they've lost something in there, and that's usually because they inserted it into their vagina and now they can't find it manually or digitally, meaning with their hand and fingers. So the reason for those types of problems is usually because something has become lodged in the salpinx, so maybe it's a broken condom or a tampon or what have you, and the person just can't quite get their fingers in there at the right angle to feel it and therefore pull it out. And so they typically visit the emergency department and have, some assistance doing that. So just FYI, if you have kids and you're going to give your kids a, sexual education talk and some of them have this anatomy, it would be good to explain to them that they cannot get anything lost in there. And if they feel like they have gotten something lost in there, that it's probably just in this weird little corner and it's totally possible to get it removed safely and they shouldn't freak out. I had friends in middle school who thought they were going to die of toxic shock syndrome because they thought that somehow the tampon they inserted disappeared, and it was a big to-do, and if they had just been told what I just told you, none of that would have happened. All right, so let's Let's see what the best uterus view is. I really would love it if this ureter was like out of my way. All right, that's fine. We'll do that. All right, so here we have the uterus. And as you can see from the model, although the vagina is inferior and also posterior to the bladder and the ureter, the uterus tilts forward in the pelvis such that it's above the bladder. And this is notable and interesting because when the ureter is housing a fetus, that fetus is basically tap dancing on the person's bladder at all times. So there's an anatomical reason why you should let pregnant people use the restroom ahead of you, especially if they have to pee, and that is because they have a tiny person tap dancing on top of their bladder, which makes the urge to urinate much more, frankly, urgent. All right, so we've got our cervix there, which is the neck portion that essentially pokes down into the vagina. There we go, perfect. And then the cervical canal is this portion. So you can see how there's this dividing line, and then after that, the uterine wall gets smoother and opens up a little bit. But before that, we've got this wrinkly bit. So the cervical canal is the wrinkly bit. So it's the passageway inside of the cervix. So this is the length of the cervical canal. And then we've got the external os, which means opening. And then this area here is the internal os, which just means opening again. So the cervical canal is bounded on its ends internally by the internal os and externally by the external os, which is the hole that faces the vagina. So that external os is the goal for deposited spermatozoa to try to make it through this stuff and hopefully go up a fallopian tube to achieve fertilization and make a new human. All right, so that's the cervix. Now let's rotate this little guy and look at some sort of gross anatomy. Careful now. No, I don't want to tilt it that way. I want it to go more like that. Nope. Yeah, that's better. Okay. So we've got the fundus of the uterus, which is the domed top. The middle portion is the body of the uterus, and then the cervix is the neck that sticks down into the vagina. This is more of a thing that you'll be able to see on the histology of the uterus, the thing I'm about to say, but we can also see it here. And those are the layers of the uterus. So the uterus, like the vagina, is very stretchy. And it has to be because it has to grow from being relatively small to housing an entire other human being. So as you can imagine, that's quite a feat. So the innermost layer, which I'm going to make be red because periods, the innermost layer is just the layer that faces the lumen, and that is the endometrium. And that is made of a glandular epithelium that grows every menstrual cycle with the goal of providing a place for embryonic implantation. And then the middle layer, which is from here to about here, is the myometrium. Myo meaning muscle. So this is a layer of elastic tissue and smooth muscle, and that provides two functions. One, it's stretchy so that it can grow to accommodate a growing fetus. And the other is, because it's smooth muscle, it can contract and expel said fetus when it's time for baby to be out and not in. And then surrounding all of that, which is made of connective tissue, is the peri. That should be RI. And that is just the connective tissue covering over. All right, so moving right along. I'm just going to tilt this a bit. And we're going to make it a teensy bit smaller. There we go. Okay, so we have... nope, that's going to match the background way too much. So we have 2 ovaries, which is the female gonad, meaning the structure that produces gametes, haploid sex cells. And then attaching the ovary to the uterus is the ovarian ligament, which just helps stabilize it. Like all of the stuff, it can't be flapping around in your pelvis, bumping into other organs. We have to stabilize it. So the ovarian ligament basically does that. It helps make sure that everything is held in place. And then we've got the fallopian tube, which I'm going to circle it instead of... because it's not homogeneous. It starts out pretty narrow and then it widens as it approaches the ovary. It also takes a turn. So it's kind of like a funnel more than a tube. And this is the fallopian tube, which is also sometimes called the uterine tube. You can use either. So the fallopian tube is how an ovulated egg makes its way into the lumen of the uterus. And it's also the place where fertilization is supposed to happen. So contrary to what many people believe, fertilization is actually not supposed to happen in the uterus. And if it does happen in the uterus, that typically results in a spontaneous abortion, meaning the pregnancy just doesn't stick. And the reason for that is there's some development that has to happen as the new individual, the zygote, makes its way down the fallopian tube. It grows and changes so that by the time it gets to the uterine lumen, it's in an advanced enough stage that it can burrow into the endometrium and begin to build a placenta. If the zygote is formed in the uterus, it's usually too late and the embryo is in too early of a stage, and it can't implant before menstruation takes place. So, fallopian tube ends in some little projections. So you can see these little sort of pokey outy bits, and those are called fimbriae. So they're little finger-like projections. And I wonder if this model actually shows it. Let me check. I'm just going to do some rotating here. Oh, yes, this would be the side. Come on. So touchy. Okay. It kind of shows that it kind of doesn't. So this picture makes it look like an ovulated egg would just go right in here and everything would be fine with ovulation 100% of the time. In reality, there is no connective tissue or other connection between the opening of the fallopian tube and the ovary. They're not physically attached to each other. They're just very, very close to each other. And there's no guarantee that the follicle that makes it to the ovulatory phase is going to be at the tip of the ovary. In fact, they're often not. So like this is a leftover of an ovulation, and this ovulation would have happened like off of this surface. So that begs the question, if there's no guarantee of where ovulation takes place, so you could ovulate from here, for example, and then the the ovulated ovum would be like floating around out there. How does it get into the fallopian tube if it's like over here, for example? And the answer is the fimbriae. So the fimbriae are full of tiny arteries, and right around the time of ovulation, due to the parasympathetic nervous system and some other things, those arteries become pressurized and they gently pulsate with the rhythm of the heart. That pulsation creates vortices in the pelvic fluid that hopefully draw the egg into the tube. But that doesn't always happen. Sometimes the fluid vortices fail or ovulation happens in a weird place, and the ovum ends up just in the pelvic cavity. It's not common, but it does occur. And even more rarely, sometimes, because there's no physical connection between the fallopian tube and the ovary, and sperm are good swimmers, sometimes they accidentally swim out. And again, rarely, but not as rare as you might think, the sperm can fertilize the egg in the pelvic cavity. So this is one kind of ectopic pregnancy. So this word here means a pregnancy that is not in uterus. So it's in the wrong spot. But not all ectopic pregnancies are created equal. So the overwhelming majority, so greater than 90%, are in the fallopian tube. And then the remaining ones are all kinds of weird places. So rest are pelvic, usually. There are even rarer cases, like the tiniest of cases, where the fertilized egg, for whatever reason, makes it to a really weird place. For example, I read a paper recently where there was a ectopic pregnancy that ended up implanting in the liver, which is like, but that's really rare. But regardless, ectopic pregnancy is actually pretty common in general. Of ectopic pregnancies, most of them end up happening in the fallopian tube, but there's a very small number of them that actually just happen in the pelvis. So the problem with ectopic pregnancies, among other things, is that the uterus, and specifically the endometrium, that is specifically designed to join with the embryo in a group effort to create a placenta. None of the other organs in the pelvis or elsewhere, certainly not the liver, none of those organs have the capability to build a placenta. The endometrium of the uterus is specialized in that way. So for that reason, ectopic pregnancies are not viable in the vast, overwhelming majority of cases. And one of the things that an embryo does is it puts out what are called angiogenesis factors, which is a cell signal that says, hey, we need arteries here. And sometimes they'll just arrive on an artery. So the pregnancy is in the wrong place. Blood vessels are being recruited to it. That creates a really, really high likelihood that the developing embryo at some point will end up rupturing the artery, which causes very severe internal pelvic bleeding. And that, if left untreated, leads to death. So I'm being explicit about all of this for a variety of reasons, but one of them is that it's very clear from the political debates happening currently which I won't weigh in on because it's not appropriate here, but it is appropriate to make sure that everyone understands the science of what's being discussed. That's very important, just to be an informed citizen so you can make good decisions about how you vote and all that stuff. It is really important that people understand this, and I think it's pretty clear that a lot of people don't. Regardless of their side on the issue, public understanding of the biology of this is very poorly understood by the regular average person, and that creates a lot of incorrect ideas being promoted and repeated, and it can result in very, very bad consequences for people who are just trying to, get pregnant and survive, right? So that is what all of that stuff means. You're also welcome to ask me questions about it, but I think it's just important that we are, using medically accurate terminology when we talk about this stuff. All right, so that's the fallopian tube. That's the fimbriae. Let's see if there's anything else I missed in here. Oh, round ligament. So this little guy that's like sort of swooping off here, it's not a tube, it's just a ligament. So there's all kinds of stuff that kind of stabilize the position of the uterus and the ovaries within the pelvic cavity. That's one of them. And if I missed anything, I'm not going to talk about what's going on in here because that is a topic for histology, not a 3D anatomical model. So I think actually that is all of the stuff on my students' list. So, in conclusion, thank you for your attention. Now I have it upside down. And the next video is going to be the same deal, but a run-through of male pelvic anatomy, which I hope you find just as interesting. Both sexes are fascinating. All right, thank you for your attention and see you in the next video.